All right, now I'm going to talk about the aspects of motor development that we look at. And to me, motor development is the most important thing that we can help a child develop. And that happens through, obviously getting rid of primitive reflexes and retraining vestibular system and eyes and that type of stuff. But when I talk about motor development, these are things that I want you to look at and I want you to record, because when these things change in a kid, they're really great for like pre and post videos, for showing like that, by working on these reflexes, their motor skills improve. By working on their balance centers, these motor skills improve. So they make really great educational videos as well. But also they are very important for understanding neurologically where that child is and what systems are more or less weak. So we're going to talk about that. Okay, so this first one, this is in relation to gait in relation to primitive reflexes. So there's a couple different movements you can do and record, and you want to see what happens with their upper and lower body working together. But this first one, this kid's going to walk on the edges of his feet, and what you're going to see is his arms are going to start rolling in like this. And I'm going to check this on all three of these kids. Their arms are going to roll in like this. They're going to turn their toes in and their arms are going to roll out like this. They're going to turn their toes out and their arms are going to roll out like that. It's because they still have an ATNR, an STNR, and a tonic labyrinthine reflex is why you're seeing that in these kids. So here we go. So you can see as he walks on the edge of his feet, everything rolls in, and even his face, he has a harder time coordinating. He should be able to walk with a normal arm swing when this reflex is, or when he walks like that. And then as they keep going, it gets worse, and typically worse and worse. And then I have him walk toes in, which number one is just hard for him to motor plan in the first place. So that tells you a lot about his motor cortex, his motor planning as well, or his higher cortex. But then here he goes, he's even just trying to turn his toes in. Do you see what happened with his arms there? Let me go back. Even just trying to turn his arms in, or turn his feet in, look at his arms. So even just cognitively trying to do it, this is all in the way of proper motor planning. And then this is him trying to do it with his toes out. So you'll see his arms start rolling out. So when these reflexes don't go away, your upper body and lower body can't work independent of each other. So that's why you start seeing these, when you turn their lower body, do stuff with their lower body, their upper body starts to rotate their feet in, flex their internal flexors, their flexors start to activate. You turn their toes out and you get extensors, you turn their toes in, you get flexors. So that shouldn't, at this age, I mean after like that first year, that should not be present. So here's another example. Same thing, walk on the edge of his feet, watch his hands on the outsides of his feet, start rolling in. Not bad. His isn't as strong on this one, but he also had a harder time doing the test appropriately. So sorry for my poor cameraman skills. But you can see when he even thinks about it, his arms roll in. Because every time if I had the volume on, every time I said, turn your toes in, and you can see how hard that got for him and how you get that really abnormal posture. And then, let's see, this one. I want to point out a couple of things in this child's case of when you have from just a gait analysis perspective, which I'm going to show you a video on here. What happens is when your frontal lobes aren't functioning well, think of an older person, like an elderly person, how they start getting more hunched over, and they eventually get into walker and they're walking really hunched over. That's because their frontal lobes have degenerated to the point where their frontal lobes can't inhibit flexor muscle tone, so now everything's pulling them forward. You can see here, his posture is the same as an old person because his frontal lobes aren't functioning well enough to inhibit this flexor muscle tone and allow him to create extension. So just a important point there. Walking on the edge of his feet, he has no arm swing, meaning his frontal lobes aren't functioning well enough and his flexor muscles are overfiring, so he has zero arm swings at all. Again, toes come in, arms roll in. It gets bigger and bigger as they go typically. Just like any other reflex, the more you stimulate it, the worse it gets. Toes out. It's a really hard time motor planning this. He's really slow. Again, that's a frontal lobe issue. Arms rolling out, especially on the right side. So you can even take these and go, okay, which side's stronger? Like, for example, some kids, you might have them rotate their toes out, their right arm rolls out, and their left one is walking perfectly normal, which is wild. You bring their toes in, their right one comes in, and their left one's walking perfectly normal. So you can start seeing, oh man, this is way stronger on the right side than the left side, and you can point that out to the parents. Okay, this is I'm hoping this plays with volume. This is abnormal. If it doesn't play, I'll just post it, so hopefully it plays. Okay, so when it comes to gait analysis in kids, we're looking for a few different things. Number one, I want to look at their posture when they're walking. If they're really hunched over like this and they look like an old person, it tells me a lot about their frontal lobes. Their frontal lobes isn't creating enough flexor tone, suppression of their flexor tone, so everything's getting pulled forward. Also tells me that their spinal extensors aren't activating, their vestibular system isn't activating, so that child's going to have poor balance. They're going to have poor core stability, and they're typically going to have a frontal lobe issue. But then the next thing I look at, besides like that antalgic posture, is there any head tilts when they walk? Do they walk like this? If they do, it tells me that probably their left vestibular system isn't firing as efficiently. They don't have good perception. They're falling more towards the left, so they don't have good input to that left side. So I'm thinking more left vestibular system, left cerebellum. And a point off of that is my head was tilted to the right. The reverse of that could be true. If my head's tilted to the left, it's going to be more typically right vestibular system, right cerebellum. We're not getting the same input there. So with that, I'm seeing a lot of spinal curvatures, like this type of curvature, more vestibular system. But when they actually walk and they make a gait, I look for a couple things. I look at their arm swing a lot. I look at the angulation of their feet. I look how fluid it is. I look how wide base their gait is, because there's something called a cerebellar gait where they walk with kind of wide steps, so they don't have a good base of support. Their balance center isn't well integrated, so they walk with a really wide step when they walk. That's a cerebellar gait. And you'll also see when that's going on, a lot of times their toes will come in and they get these like big arm swings with it, because when your cerebellum is integrated, you don't create enough tone, so you get too big of arm swings. So simple way to think of it is, the bigger the arm swing, the worse the cerebellum. But then I look from side to side. Does one side not move and the other side moves a ton? I'm starting to think, is their left, in this case, if this arm isn't moving, is their left frontal lobe not firing efficiently and shutting down that flexor muscle tone, so we're getting a lot of more contraction on that side? Or is their opposite cerebellum not functioning well and they're getting too much, they're not getting enough stability, so this arm swing looks a lot bigger. So I'm taking this into consideration when I'm watching a child walk, of this arm has a big arm swing, this one isn't moving at all. It starts to tell me, I start thinking, what's going on with that right cerebellum? What's going on with their left frontal lobe? So that when I go into testing, I can look at these things. And then if, for example, we have too much, not enough activity of our left frontal lobe, what we're going to see is this leg's going to start turning out. So if when they're walking, their toes pointed out this way, but this one's walking forward or straight, starting to tell me about that tone. Or maybe we're seeing this side even coming in, and because we don't have enough tone in our glute, which is getting to tell us about their cerebellum. So we're looking for, is there too much movement on one side? Is there not enough on the other side? So we're looking from right to left. Then another really interesting thing you'll see is, if kids don't feel the ground well, they'll have like almost like a slappage gait sometimes. Like you can almost like hear their feet like clogging along. That's because they don't feel the ground well, so they're pushing too hard into the ground to get more sensory perception. So when that's going on, I start thinking about their parietal lobes. I start thinking, do they even feel their feet? Because a lot of kids sadly in the United States are having issues with diabetes at a very early age. So they're starting to even lose some sensory perception of their feet at a really young age, which is really sad. But or else, if not, from a developmental perspective, I start thinking, what's going on with the parietal lobes? Those are the main things I look for when looking at gaits. But the biggest one by far you're going to see is issues at the cerebellum. You're going to see a wide stance gait. You're going to see a forward posture. And you're going to see these big arm swings that are really sloppy looking arm swings. Their whole trunk is going back and forth with every step because they don't have core stability. And that's really a cerebellar issue. And you're going to see that
on pretty much every patient you see that has developmental issues.
Okay, so this is like a lot of times I'll record this on as many kids as I can, especially the primitive reflexes one, how they walk, but even just like when you bring a patient back, just watching them, how they move, you can start getting a lot of tips into like, man, that left arm is moving a ton, that right one isn't moving at all. What's going on with the cerebellum? They're really forward, a poor posture. They're when they walk, their trunk's going back and forth. They don't have any head stability. I'm starting to wonder about what's going on with the vestibular system, what's going on with their balance centers, what's going on with their midline cerebellum, all of those things, even before you ever even look at a child, and you just bring them back to the room and watch how they walk. You could go up to the parent and go, hey, they have balance and coordination issues. They have, are they having issues with the attention if they're, really forward? They have an anxiety. Are they having repetitive movements? You can tell a lot of that just by how they move and understanding what areas of the brain help coordinate, different things. So, okay, posture. Posture is a huge thing, and like I had the blessing of being able to understand this from like a chiropractic standpoint. Of we know when people have appropriate cervical curves, they have way less strain on their brain stem. They have way less strain on their cervical spine. Cerebral spinal fluid moves way better. So like we got to learn that from the aspect of just overall function improves as we get those normal curves. But posture also tells you a lot about the brain, which I came to realize, and I didn't learn that in school. And so I want to talk a little bit about that as well. Okay, so a simple way, if you're looking at me from the side, and if we have a good cervical curve and a good lumbar curve, so that lateral curvature, that tells us a lot about the cerebellum. So when we start to lose that good curve, pretend I'm from the side again, when we start to lose that good curve and it starts to straighten out, it starts to tell us that our midline cerebellum isn't activating, or the spinocerebellar pathway isn't activating the intrinsic muscles appropriately, and we're losing that stability. And what you'll also see with that is when kids or people just in general, they tip their head and their neck just pops all over the place. That shouldn't happen. That's a lack of stability of the cervical spine and those intrinsic spinal muscles. Therefore, they have a midline cerebellar issue. So FYI, when we look lateral curvatures, we're thinking cerebellum, midline cerebellum. When we start seeing curvatures to the side, like for me, for example, like let's say I had a head tilt this way, this shoulder's elevated, and my posture's all changed because of that, we're starting to think of a unilateral or one-sided vestibular issue. So if I'm tilted like this and my ear is elevated on this side in comparison to this side, we're probably thinking more a left vestibular issue, or maybe even an eye tracking issue, an eye alignment issue. That can do it too. But in that case, if we have a vestibular system that's off, we're probably going to see some balance issues. We're probably going to see some anxiety. They're probably not going to like busy places. Maybe they have some behavioral issues, different stuff like that. So looking at forward, backwards, side to side, where are those deficits, or what's going on there? If we have a really forward posture, again, we're thinking the frontal lobes. What's going on? Why are they not shutting down flexor muscle tone? And what's going on there? So, okay, so most kids you see, they're going to have very poor posture, especially from the side. This is due to lack of cerebellar development and core stability. When the midline cerebellum is not developed appropriately, you will see lack of lumbar and cervical curves. You also see balance, eye tracking, cognitive issues in many cases. You also see the same issues in elderly people that have brain degeneration. And the reason why you'll see cognitive issues is, I don't remember where I read this, what book I read it from. It was really interesting, though. It might have been Malila's textbook. I'm not sure, but it was talking about as the spine moves and moves appropriately, it generates gamma oscillations in the cerebellum. Well, those gamma oscillations from the cerebellum fire into the frontal lobe to keep it active. So when we have good gamma activity in our frontal lobes, we can focus. When we don't, we can't. And that's produced through spinal movement, which was really interesting. They compared it to like a windmill generator of generating these oscillations for our frontal cortex through movement. And if we can't move appropriately, we can't produce that appropriately. So just FYI there, that's a really good clinical tip there, is to having a lot of cognitive issues. What's going on with their movement? in their core stability and activation of those deep intrinsic spinal muscles. Another common presentation is lateral head tilt. This is often due to a unilateral vestibular imbalance, lack of postural reflex development, which we're going to talk about. Those are reflexes to keep your head level at all times, or ocular tilt reactions, where the eyes maybe didn't develop appropriately and they're not compensating appropriately, or a extremely common reason is torticollis. So if torticollis was present at a young age and then wasn't dealt with appropriately and rehabbed appropriately, then they don't develop their asymmetrical tonic neck reflex appropriately. And then so let's say a kid develops their head tilt like this, right? Well, now their eyes have to roll inside of their head to keep their world level. If that happens, now this is their new norm. So if they never rehab that to get their eyes strong enough to keep their head level, now they have a head tilt. And then as that child develops, now they start developing compensations for that. Okay, core stability. A couple of my favorite tests to do for core stability. And when I look at core stability, I am looking at and thinking of midline cerebellum. Are we stabilizing the middle of our body, our core stability? That's my midline cerebellum. The couple of my favorite tests, just easy, bridges, glute bridges. So I like to see can hold a glute bridge. They should be able to hold a glute bridge quite easy. I mean, that shouldn't be a problem, especially with their arms on the ground, both legs separated a little bit. They should be able to hold that. If you start seeing a lot of shaking and moving, or what's called truncal titubations, that's a weakness there. They should be able to do a Superman. Pretty much after probably 4 or 5, they should be able to do a Superman pretty easy. They should be able to do a side plank on their knees for sure. It is amazing how many of these kids you're going to look at that can't do any of these activities, even for 2 seconds. It's really wild how weak a lot of these kids are. And unless you start isolating them out, and I mean, you need to show them hey, your kid can't even do a Superman. They can't even lift their head up when they are on their belly. An infant can do that. They can't raise their arms when they're on their belly. An infant can do that. That's how weak these systems are. And these systems directly fire into our higher cortex. So checking those, a couple really easy, simple things to do to look at the midline cerebellum. So I want to talk a little bit about reflexive movement. And the reason for this is, so I'll talk about a case here. I had a kid that came from Illinois, and I couldn't get rid of his primitive reflexes. We were 2 or 3 days into an intensive. I couldn't make any change. I was trying everything that I could think of. And I just happened to read a book over cerebral palsy and something called Feldenkrais method. And it was talking about how slow range of motion can retrain motor patterns. And I was like, well, I've tried everything else. Let's try this type of thing. And it worked. So I did really slow range of motion. I did 6 hours of extremely slow range of motion to try to retrain this abnormal movement pattern. I'm going to talk about that pattern here in a second. But I have found that when this pattern is going on, this is a really effective strategy for getting rid of the reflexes. So when a kid moves, for example, let's say they're laying on their back, I should be able to move their arm fluidly. Zero restriction. I mean, unless they're fighting me, but normally, no restriction through really any range of motion. Through the wrist, elbow, shoulder, low back, hips, knees, ankles. I should have zero issues with moving them. It should just be nice and fluid movement. But when kids have what's called reflexive movement, where that's what I'm calling it. I don't even know what the actual true name of it is, but I'm going to explain the pattern. When we start moving them, they have these jerky, quick, abnormal movements. And for example, I had that one kid I was talking about, I would move his wrist and his whole body would move. It was the weirdest thing I had ever seen at that point. Now I see it all the time because I know what to look for. But we'd move them and other stuff in their body would reflexively move. We'd turn their head and their whole body reflexively moves. And then even just moving individual joints, it's it almost feels like cogwheel rigidity is really what it feels like, what you see in Parkinson's. So as you move them, it's not a smooth, fluid movement. You get all these starts and stops in their movement. Well, come to find out, I ended up figuring out that this was related back to the basal ganglia, just like a Parkinson's patient, where they have this really abnormal, weird movements. And when we work through really slow range of motion, I mean, in starting distally and then coming proximally. So like starting out by just moving fingertips and getting that movement smoothed out. And anywhere where we have that resistance, not forcing through it, but working on like maybe figure eights or working around that movement, really slow ranges of motion, same through their elbows, shoulders, hips. And you don't have to do this as a provider. You can teach the parent, we want to move through these really slow ranges of motion, retraining, smooth out this movement, almost like recalibrating that movement. And the parent can do it at home, say, hey, they're going to need like an hour or two a day. Or you can pay me. I'll do it for an hour or two a day while I'm doing other stuff. That's no problem. But we can work through that slow range of motion and start to normalize that movement. And it's really effective. When that's going on, that's the only thing that I've found that gets rid of their primitive reflexes extremely quickly is by normalizing that movement. And now it's became one of the most important things that I do with kids is looking at their movement and making sure it's smooth. Like, so before I ever work on primitive reflexes, before I work on vestibular stuff, eye stuff, I want to make sure that movement is normal. I'm going to show you guys actually something real quick. I'm going to jump way ahead here in the presentation because I want to show you guys this kid's eye tracking. This is a perfect case of this. So all we did for a week intensive, I shouldn't say all, we did some other stuff too, but the majority of what we did was work on rehabbing his movement. He went from, if you look at the top there, the 45th percentile in all aspects of eye tracking to the 82nd percentile in all aspects of eye tracking, simply by working on getting his range of motion normalized, which helped him to get rid of his primitive reflexes. But this kid had that pattern. He had a reflexive abnormal movement. You can see on the left side, he's trying to track a dot going in a circle versus the right side. Left side trying to track a dot going side to side versus the right side. Same with up and down. Up and down still a struggle, but that develops a little bit later. Same with jumping his eyes from target to target to target. This kid came in with a reading issue. I wonder why. He couldn't track his eyes. And just by rehabbing his movement, because he fit this pattern, his reflexes went away. Therefore, his eyes could start functioning more appropriately. So let me go back here. Okay. I see this pattern most often in kids that have a basal ganglionic issue. So maybe they have PANS pandas. Maybe they have a lot of excessive immune system reactivity. So their immune system's overactive, and therefore they're getting a lot of neural inflammation, a lot of food sensitivities like dairy or gluten. A lot of times they'll have sensory issues. They'll have severe anxiety. Maybe they'll have repetitive like OCD activities or tics. You'll see this abnormal movement in. Many times it takes me 2 to 5 hours of range of motion rehabilitate to rehab it. So, but I'm going to show you just, Dr. Lauren did a quick video explaining kind of how to look for that. So,
health and development of your child's brain is simply assessing their range of motion. Abnormal movement or reflexive movement with this assessment is indication of dysregulation of their basal ganglia. That's the deep part of our brains that have a lot to do with motor learning and even behavioral regulation. So when we're checking for range of motion, we'll have a child or an individual lay on their back, nice and relaxed, and then we'll actually lift their leg up and we'll move them in slow figure eight non-linear movements. Think almost like a corkscrew or a hula dancer. And as you move the child, the movement should be nice and smooth, but what you'll notice with some kids with basal ganglia dysregulation or inflammation is that they'll have a lot of reflexive movement. So when you go to straighten their leg, it might tighten up. Or when you go to bend their leg, they might actually try to extend their leg. So as you move your child's leg, you want it to feel nice and smooth. So you can check their upper body and their lower body and be really sure to challenge those ranges of motion. So nice and smooth, should be very comfortable, should be really relaxing. And this technique that we use to assess can also be really therapeutic. So it's a way at home, if your child does have
if they have abnormal movement, to rehab it, simply put. So when I figured that out, like, I don't know, a couple years ago now, that was a game changer for getting rid of primitive reflexes, especially in that population. I mean, in some kids that come in, I literally will do 10 hours in the first week of just range of motion to get that normalized. And usually when we do that, their reflexes go away. So it's a really important aspect and something really important to look at. I think it's probably one of the most important things to look at, because if we don't have normal full range of motion that's smooth and efficient, we can't develop these reflexes appropriately because our motor systems just can't develop appropriately. So, and I'm going to talk to you guys about like next module of how we do that and work you through that, and just so you understand a little bit better. I do need to talk about spasticity and upper motor neuron findings just a little bit. There's, in school and stuff like that, we learn all kinds of stuff about that, all the orthopedic tests for it, all the neurological tests for it. So I'm not going to like beat it over your head, but I do want to make sure that you're just kind of aware of, because like, for example, I learned in school, if a kid has a Babinski reflex, they have an upper motor neuron lesion, therefore they need an MRI, which is not true. So in all cases, but if they have a Babinski mixed with clonus, mixed with upper motor, more or other upper motor neuron findings, then yes, they do. So I want to make sure I talk about that, so I'm not leading you guys down a wrong path, and you make sure you know what you're looking for. So there's a difference between spasticity and tone imbalances. So spasticity, when we're talking about that, that's like a kid that had a stroke. Now they have spasticity, and they have a lot of tightness, which that slow range of motion that I just talked about, that reflexive movement, that technique works great for helping to normalize a lot of that range of motion, just FYI. But we always want to rule out an upper motor neuron findings with spasticity if the child can be referred for an MRI. So most of the time, a kid comes in with spasticity, you're not going to be the person that finds it. They are going to have already been to a neurologist, they've already had an MRI, but it is not. I've had probably 3 or 4 different true upper motor neuron findings that no one knew about. I've had kids with strokes that I was the one that found them. I've had kids that are missing portions of their brain, like their corpus callosum, because they never had a good neurological exam. I mean, or even like they went to their primary and they didn't assess it, which is wild to me. If there's a true upper motor neuron findings, you're likely not going to be the first one to find it. But I found my fair share. So if you find like a Babinski reflex on the bottom of their foot and their toes come up, then a Hoffman sign where you, like let's say this is my shin, and you stroke up their shin and their toes come up, and they have hyperreflexia. So you take a reflex hammer and you hit their knee reflex and get these massive movements, or you hit their Achilles and you get big movements. Or even like their hand, you can hit their hand if it's in their upper extremity, like on the palm of their hand with a reflex hammer, and you'll get reflexive movements, like really big ones. Or clonus, which if you take the bottom of their foot and you push it up really quickly, you'll get boom, 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 boom. You'll get this really quick movement. That's called clonus. That's an upper motor neuron finding. So if you find a Babinski, that's not a big deal. If you find a Babinski mixed with clonus, hyperreflexia, and other upper motor neuron tests like a Hoffman's, or there's a whole bunch of them, then you need to, and they don't know that they've had a stroke or an upper motor neuron they have something going on in the brain, because kids can have tumors, it's different stuff like that, and they don't know that's going on. They need to be referred out for an MRI. Just plain and simple. If you find multiple of those, it's a big deal. If you find just a Babinski or just a primitive reflex, with none of the other findings, rehab it and it'll go away. But gotta make sure that I'm making sure you guys are aware of those important things, because those kids, whatever it is, I've had kids that are literally missing portions of their brain, and it completely explains their developmental issue. We end up finding out it's a genetic issue because you're just the person that just found the random finding. You send them to someone that looks into all that other stuff. You don't have to be the person that knows all those things. You just got to get them to the right people. So, okay, complex movements. These are things that I like to record for kids, because a lot of times they can't do it. You get rid of the reflexes, they can. Or a lot of times you can't do it, you rehab them, they can. So I like to look to see if they can skip, jump over things, jump up things, upstairs, downstairs. See if they can do a jumping jack. A lot of kids can't do jumping jacks. Catching, throwing, balance activities, really any gross motor skill. I like to record it and show improvement over time, because those make really good videos for, number one, showing the parent, this is what's happened, this is how they've improved, but also for social media stuff, you can show there's there's so many kids that can't do a jumping jack. And they can relate it back to, oh, they still have primitive reflexes, or they have these other issues. They have a motor development issue. Now that parent goes, oh, I should probably take my kid to get this assessed and make sure they can do it. Or, they test it at home. They go, hey, Susie, can you do a jumping jack? And they can't do it. That's a big deal. And then they start realizing, hey, maybe there's more going on. Maybe my kid's learning issue is really a motor development issue. Maybe there's more going on than my kid just struggling to read. Maybe there's a lot more going on that we need to look at. So recording all those things, then doing educational videos over them. Hey, your kid at this age, they should be able to balance for this long or do this activity for this long. If they can't, it might be indicative of these reflexes. Then you show those same reflexes in that same patient that can't do a jumping jack. And then you can go, after we got rid of these reflexes, now he can do a jumping jack. It's great. Great way to show improvements is just by looking at basic, complex movements that are everyday movements that kids do all the time, and then relating them back to the true neurological findings. Okay, cerebellar tests. So I put these in the motor development because the cerebellum is really what coordinates our motor skills. Okay, so the midline aspect of the cerebellum, so if you look at the picture in the upper right-hand corner, that midline aspect where the vermis is, simply think of it all the way down is it helps coordinate everything in the midline of our body. Core stability, vestibular system. So that first test, the Mann's test, when we put one foot in front of the other one, we're primarily isolating out this midline core stability. So I want a kid to be able to do that. Depends on their age. Age gets a little bit tricky here, but like, for example, with their eyes open, if a kid's 3, 4, I expect them to be able to do that with their eyes open for, 10, 15 seconds. A lot of kids literally can't even put their foot in front of the other one, right? So as they get older, like that 7, 8, 9, I expect them to be able to do it with their eyes open for a good amount of time. 30 seconds to a minute, no problem. Eyes closed, at least 30 seconds. A lot of times at that age, once I get done rehabbing them, they'll close their eyes in that position and they'll be able to, I'll stop them at a minute because they have no problem with it anymore. So the looking at that midline aspect is real important. And then one-legged Rombergs, we're starting to isolate out the hips. So like from a functional standpoint, when we're looking at the cerebellum, we have that midline aspect, then one-legged stance, we're isolating the hips, and then but we can do other tests as well, like rapid alternation, where your arms are straight, but we're rotating from our shoulders. So we're starting to isolate our shoulders and hips, which is more that intermediate zone coordinates our shoulders and our hips. So when we do a one-legged Rombergs, you might find that they can stand on their left leg with their eyes open for 20 seconds, but their right leg for 5 seconds. Now we're starting to see an imbalance. Then if you go here and you do rapid alternation, their left side looks really good, but their right side is really uncoordinated. They're starting to try to use it's not nearly as, I can't do it, but I'm really quickly here, but then really slowly over here. They're not coordinating that right side. Now we're going, hey, what's going on with their intermediate zones of their cerebellum? They can't coordinate their right shoulder, right hip appropriately. Then we can get into rapid alternations, and that's going to look at more of these lateral zones, the lateral aspects of our cerebellum. So our elbows are in nice and tight. Now we've locked down our shoulders. Now we're just isolating our wrists, which we're looking to see how fast can we coordinate that. We might see that the left side's really good, the right side's challenging, and I'm changing that because that was my example in the first one, because typically we're going to find everything more on one side than the other side. So if my right shoulder and right hip aren't as good, typically the right coordination isn't going to be as good either, because that whole right side isn't developing or maturing, or vice versa. Maybe it's the left side. But we can do rapid alternation. We can have them put their hands on their laps and do, so let's pretend my hands are on my laps. We can do quick rapid alternation, looking to see, is it symmetrical? Can they do it both sides? Is one side slower than the other side or less coordinated? Are they starting to activate more muscle groups to try to do the same activity? That tells us about efficiency. We can have them do quick tapping like this. We can play the piano. So coordinated activities, and seeing, is one side really coordinated or more coordinated and the other side's not? If we're seeing both sides aren't good, they can't, they're trying to do this type of thing and their hands look like this or look like they're waving at you and they're trying to flip it. Or here they're incorporating like their whole body to do it. that's a bilateral issue. So bilaterally, we're not coordinating. That's going to tell me probably it's most likely more of a mitochondrial energy production issue that is what's the underlying cause of it. So we got to address that at the same point. Because remember, I talked about earlier, if it's one side, if it's one network, if it's one area, that just needs rehab. If it's global, and we're seeing both sides of the cerebellum being involved, the entire cerebellum, it's probably metabolic. So it's probably a bigger issue that is causing it. It still needs rehabbed, but we got to figure out that underlying mechanism, because or else, again, they're going to go home and going to have the same issue. You could rehab and make all these great improvements, but they're going to go home and come back with the same issue 6 months later. So, which we never want for anyone. Okay, when looking at movement, if a child has difficulty planning or initiating movement, then it's from his frontal cortex and motor cortex. So when we look at movement, just a couple basic principles so you understand. If we have a hard time initiating the movement, so you say, hey, I want you to raise your right hand. And it takes them all to think about, okay, well, this is my right hand, and I gotta raise it. That's one thing. And so let's just say, I want you to touch my right finger with your right hand. And they go, okay, I gotta think about that. That's my right hand. I gotta move it, and I gotta touch it. So it takes them longer to process that and plan that motor movement to do it. That is our frontal cortex. If it's not coordinated, but it's quick, it's our cerebellum. So if we say, hey, touch my right hand, and they go to touch it, but their movement is not coordinated and they touch, so that at the end they have a tremor, an intention tremor, and they go to touch, that's a cerebellar issue. So that's why a good cerebellar test is you have them, so you're standing in front of them with your finger, they touch their nose, then they touch your finger, then they touch their nose, and at the same time you move your finger, they touch their nose, touch here, and as they come back to touch their nose, you move your finger again. They touch here. This is a great test for looking at, can they coordinate their movements? So, but if it's smooth, it's good. If they come, when they go to your finger, if there's this tremor when they go to do it and hit it, that's a problem. If they come back to their face, there's a tremor to hit their nose. Tremor. It's called an intention tremor, because I'm intending to do something. There's a tremor with it, intention tremor. That's from our lateral cerebellum. So they can do the movement quickly, no problem, but they can't make it smooth. They can't make it smooth at the end of their movements. That's a cerebellum. If it's like, I want you to touch my finger, and they having a heart, like it's really slow, but it's smooth, that is a frontal lobe motor planning, motor cortex issue. That includes not only your gross motor stuff, but fine motor skills, speech, especially cognitive processing, eye tracking. So like, for example, if I want to jump my eyes from here to here, if it's slow to jump, that's from your frontal lobe. If it goes past it and has to come back, that's your cerebellum not coordinating it, stopping on time. Or maybe it jumps short and has to make another movement. That's the cerebellum not coordinating it. It's a quick movement, but it's not accurate. So when we look at accuracy and smoothness of movement, we're thinking cerebellum. But we're looking at speed of movement and velocity of movement, we're thinking higher cortex, frontal lobes. Okay, so a few different frontal lobe tests. I should do this while we're, because like if you're looking at their movement, you're like, hey, their movement's slow. It looks coordinated, but it's slow. Now we got to look at their frontal lobes. So that's motor planning. Hey, I want you to touch your right foot with your left hand. I want you to, I want you to climb this rock wall. I want you to, X, Y, Z. Any type of motor planning activity we can use to start looking at the frontal lobes. And if it's hard for them, we know there's probably some issues there. But we can do what's called the modified Loria. One of my favorite ones, if the kid's old enough, is I'm going to do 3 different movements, and I want you to copy them after me. So I'm going to go rock, scissors, paper. And then they have to copy it. So then they go rock, scissors, paper. Well, if their frontal lobe isn't functioning well, they're going to go rock, scissors, paper. Like it's going to be really hard. And so I'm going to test both sides. So I'm going to do my right hand, then I'm going to do my left hand. And maybe I do 3, maybe I do 4, maybe I do 5, depending on the age. Then I can also say, like, I'm going to do a pattern. I want you to do it backwards. Now it's really activating their cognitive center. So if I go rock, paper, scissors, now they got to go scissors, paper, rock. So they got to think through that and see how good their frontal lobe is. Things like that, complex movements. So if I go, I want you to do first, third, last, second, first, third, last, second, first, third, last, second. Now we're looking at all of these complex motor skills, and they have to do them and think through them and motor plan them. Go, no-go tasks are fantastic as well. So you can do this with the eyes, you can do it with the body. A really easy way to look at go, no-go tasks is say, so first and foremost, I have them just do a saccade. So I say, I want you to look at my nose. If I move a finger, jump your eyes over to that finger, and then come back to my nose. So they're looking at my nose. I move a finger. They skip their eyes over to that target, and they come back to my nose. And I'm looking to see how quickly they do it, because again, that's a frontal lobe task. And is it accurate? Does they jump right to it or they go past it? So that's going to tell me about their frontal lobes and their cerebellum. But then a go, no go task is, if I move this finger, I want you to look at the opposite one. So after you've done a bunch of saccades, so you're going, they're doing it, they're going to the one you move, going to the one they move, go to the one you move, go to the one you move. They get kind of used to that. So then what you do is you go say, now you're going to reverse it. If I move this finger, you got to go to the opposite one. So that means they have to create enough impulse control to say, no, I'm not going to look at that. I'm looking at the other one. Because whatever moves in our visual field, our eyes are reflexively drawn to. It takes cognitive control, frontal lobe control to say, no, I'm not going to look there. I'm going to look over here. And with kids that have frontal lobe issues, you're going to see a lot of challenges. So you move your finger here, they have to jump their eyes over to this target and then back to your nose. You move your finger here, they got to jump their eyes over to this target and then back to your nose. So you're looking to see, can they create enough impulse control to jump their eyes and how fast they can do it. Because if they have good frontal lobes, they'll make good choices, they'll create impulse control, and then they'll jump quickly, because that saccadic latency is directly tied to their frontal lobes. So if it's slow, they have a frontal lobe issue. So if they can't do it, number one, and then it's slow, that's two things that tells you their frontal lobe isn't functioning well. So great little test there. And then I found this little checklist thing here. I thought it was great. So I put it in there. But so similarities, what things are the same? So a banana and an orange, what's the same about them? They're a fruit. A table and a chair, they're furniture. It depends on their age too. So this is where that comes in. Lexical fluency, say as many words as you can that start with S. That's going to be more left frontal lobe thing. Right frontal lobe is going to be more conceptualization. Motor series, this is a Loria. So this is kind of a standard one. The examiner is sitting in front of him, perform alone 3 times using left hand series, Luria motion, the first edge, palm, prompt. Now with your right hand, do the same series first with me, then alone. So he has them copy them, see how many consecutive series you can do. Conflicting instructions, tell the patient, tap twice when I tap once. So like instead of tap once when I tap once, they have to do a different activity. Tell a patient tap once when I tap twice. So to be sure that patient understood the instructions, do a series of trial runs. First 2, 2, 2, so they got to tap once, right? Then the examiner now performs the actual following series. 1, 1, 2, 1. So they have to copy it and do the opposite, which is hard. It's kind of like a go no go task, but with motor cortex. Then go no go, tap once when I tap once, do not tap when I tap twice. So then, they're just doing a series of stuff and seeing how well they can do it and then grading it. Okay, so prehension behavior. Examiner is seated in front of the patient, places the patient's hands palm up, and basically puts their hands in theirs and tells them, without saying anything or looking at the patient, the examiner brings his or her hands close to the patient's hands and touches the palm of both the patient's hands to see if he or she will spontaneously take them. If the patient takes the hands, the examiner will try again after asking him or her, now, do not take my hands. So that's actually looking at a palmar grasp reflex in a way. So, and if they can create enough impulse control to shut that down, which is interesting, then you get a total score. And then you have normative values, which is great. So FYI, I found that and I was like, that's a great little test for that. So you may want to use it. That is kind of my motor aspects of my exam. Is number one is I simply, in all of them, I want to see do they have enough stability like in their core? Can they plan their motor movements appropriately? Can they make them coordinated? When you're looking at that, you're really looking at primarily your cerebellum, you're looking at primarily your higher cortex. And yes, there's a lot of systems in between, like your basal ganglia and your thalamus and all this type of stuff that helps turn on and off muscles at appropriate timing. But your cerebellum and your higher cortex, those are the two big players in that game. So understanding what's going on there is going to get you 90% there. So that's why I'm showing you those aspects of the test more than other ones. And also remember that reflexive movement component is excruciatingly important. Of anything, I would recommend looking at that first. So there we go. Thanks for taking the time to check out this video. To learn more or to schedule an intensive or anything with my team, there's a link below. Just go ahead and click that and that'll get you to the right spot. Have an awesome day.